Hi, my name is David.
And my name is Lauren.
We are talking to you today about left ventricular assist device, or known as Lvads, and the care associated for the patient.
So our objectives for the presentation are the learner will be able to describe what an LVAD is and differentiate between bridge and destination therapy. The learner will be able to identify patients who are candidates for both destination and bridge therapy. The learner will be able to identify complications associated with LVAD therapy, and the learner will be able to verbalize evidence-based care of an LVAD patient. Do you know what an LVAD is?
No, I don't know. I have heard about it, but I don't know what it is and what it does.
Okay. So an LVAD is a surgically inserted battery-operated pump, and it replaces the work of the ventricles, and in this case we're talking about the left ventricle. The blood is shunted from the left ventricle into the aorta, and I have a video here that shows you how the pump operates.
You probably know Xerox as the company that's all about supporting hospitals using electronic health records.
So here you can see the one end of the pump gets inserted into the aorta, and the other end is inserted into the left ventricle. And the pump shunts the blood from the left ventricle up into the aorta with a kind of propeller device. Why would someone need a left ventricular assist device? There are two types of LVAD therapies, bridge to transplant and destination therapy. The bridge therapy are temporarily inserted LVADs that support patients who are either getting a heart transplant or whose heart needs time to recover from injury. The objectives of bridge therapy are to sustain life while the patient's waiting for a transplant or while the patient's recovering from injury. Then there's destination therapy, and destination therapy is used with patients who have advanced heart failure or patients who do not qualify for a heart transplant. And those are normally permanent LVAD placements. And I have a video.
Destination therapy with a left ventricular assist device, or LVAD, is a way of treating advanced heart failure in patients specifically who are not considered candidates for a cardiac transplant. The devices that we use, the heart pumps themselves, have become smaller, easier to use, implant in patients, in other words, and the indications for use have changed dramatically. This has led to literally an explosion in the use of left ventricular assist device therapy across the country, and in particular for those candidates that are not considered transplant candidates. What we're really looking at now is the implantation of left ventricular assist devices much earlier in the process of heart failure, and based more on symptoms, the inability to live an effective life, reduction of quality of life, and the inability to do the daily activities with heart failure is enough now to indicate to us that an LVAD may be appropriate. Revive It is a multi-center randomized trial testing the efficacy of a left ventricular assist device in destination therapy, but in class 3 heart failure, which means we're putting it in patients much earlier. These patients must have heart failure for at least a year. They have to have stable class 3 heart failure for at least 3 months and cannot have more than one hospitalization in the last 6 months. So they're much more stable. However, they have to show limitations. Their ejection fraction has to be less than 35%, and they have to demonstrate that the quality of life is poor because of the heart failure. There's a lot of patients out there that we're not helping. So one of the main focuses of destination therapy is to get this therapy out in the community, get it out in the hands of cardiac surgeons that can provide a better outcome for patients that are dying of severe heart failure, who may not be aware that this therapy actually exists.
So that's destination therapy. Those who qualify are those who are ineligible for a heart transplant, have long-standing advanced heart failure, have a life expectancy that's less than 2 years. Their peak oxygen consumption is less than 12 milliliters per kilogram per minute. They have worsening pulmonary congestion, and pharmacological interventions are no longer managing their heart failure symptoms. They have functional limitations due to worsening symptoms, and the patient must have, it's important that the patient has a good family or friend support system, because going through destination therapy can be very emotionally draining and physically draining. The benefits of the Lvad therapy must outweigh the risks for these patients. The objectives for destination therapy, as described in the video, are to improve the quality of life for those with advanced heart failure. Now we'll talk about patient care of a patient with an Lvad. Post-operatively, they will be immediately transferred to an ICU. The goals there are to establish hemodynamic stability. The patient will need right ventricular support now that the left ventricular is being supported by the pump. And that's through inotropic agents, which will improve contractility, and through vasodilators, which will reduce pulmonary vascular resistance. They'll also need adequate nutrition, and this depends on the patient and the patient's functional level of what, if they're able to intake through their mouth, or if they actually need some support as far as nutrition. And once they're hemodynamically stable, they'll be transferred to a step-down cardiac unit. And the goals there are to prepare the patient for discharge. They'll begin physical therapy, occupational therapy, speech therapy, anything that the patient will need to prepare them to go home and live with the Lvad. Hemodynamic monitoring in Lvad patients is different from hemodynamically monitoring a patient who has a regular heart without the Lvad. The usual means of measuring blood pressure and oxygen status won't work as well with, or aren't as accurate as with a regular patient, because Lvad patients don't have a lot of pulsality, meaning they don't have a strong pulse due to the continuous flow of the Lvad pump. Their systolic BP we try to maintain at 70 to 90, and they won't really have a diastolic blood pressure due to the pump. The gold standard for monitoring on a step-down unit of BP and MAP and O2 saturation is through, we're going to have to edit. So the gold standard for measuring O2, MAP, and BP is through invasive measures. However, on a step-down unit, the catheters used can present a lot of complications and are high risk for infection. So on a step-down unit, we try to hemodynamically monitor in a non-invasive way. With blood pressure, you're going to be using a manual cuff and a Doppler to listen for the a whoosh sound, and you'll only get a systolic BP on this. Usually we do it 3 times, and you'll average it to get the best, to get the most accurate measurement. The pump flow, this is monitored through the ventricular assisted control device. It's just an estimate, so you want to use this number in conjunction with your BP measurement to really understand the patient's perfusion status. The pump is usually maintained at a flow rate of 4 to 8 liters per minute. Oxygen saturation assessment for these patients is also difficult due to the lack of pulse. Normally you would use a sensor on the finger. With these patients, you may need to place it on their forehead or somewhere more central to get the best reading. Again, but the best way to assess an LVAD patient's O2 is to measure their BP, look at what the oximeter is telling you their saturation is, and then evaluate the patient for hypoxia, so signs of hypoxia. So if they're breathing, if they're awake, they're alert, and they don't seem that they're hypoxic, then your patient is doing well. Cardiac rhythm assessment, the EKG and the patient's actual heart rhythm will match up. However, the EKG may not correspond with the mechanical pulse of the pump. Arrhythmias can occur, and in that case, the pump flow rate may need to be adjusted accordingly. Mobility. For patients with any surgery, you want to get them up and moving as soon as they're capable. This will prevent further complications such as muscle atrophy, loss of joint movement, constipation. If they can't get up, providing them with passive range of motion or promoting active range of motion is the best way to get them moving. Driveline care. So the pump is connected through a driveline which actually powers the pump. And the dressing changes are important because you want to make sure that it stays clean. So in a hospital, this would be a sterile procedure with daily dressing changes. During a dressing change, the nurse should observe for any drainage, any irritation, any redness that could indicate infection. Nutrition for these patients is very important. You want to make sure that they're able to maintain their weight, that they don't have any muscle wasting, and it supports healing and recovery after the surgery. For adequate nutrition, we try to have a high protein diet with high protein supplements, and you would want to monitor their potassium, their acid-base balance, their phosphorus, osmolality, and magnesium.
So I have a question.
Sure.
So this device is implanted inside the heart?
Yes.
And you have a control outside?
Mm-hmm.
Okay. And then you talked about a bridge versus destination. Okay, so if I understand this correctly, a bridge would be something until they get a heart transplant?
Exactly.
Or until they recover from conditions such as a cardiogenic shock, where the left ventricle gets weak, it needs support. Okay, so that is the bridge.
Yes.
Okay, and destination is for those people who are chronically ill and are not qualified for heart transplants.
Correct.
And they get the destination.
Exactly.
And that is for life, I think.
Yeah, that is until, yep, that's for the rest of their life.
Oh, thank you.
Yep.
I just wanted to make sure I got the difference.
Yep, that's for the rest of their life.
Thank you.
You're welcome.
All right, so we talked about the various destinations and the indications for use. And now we'll be talking about complications, especially in the post-operative time. And most of these complications are a low pump flow or an output, right ventricular dysfunction, hemorrhage, cardiac dysrhythmias, device malfunction, and infection. So a low pump flow or an output is a hemodynamic emergency. So our goal is to maintain the flow index over 2.2 liters per minute per square meter or per your body surface area to ensure end organ perfusion. And our interventions for low flow outputs, assuming our right ventricular is functioning normally, is to treat with IV fluids. The type of IV fluid depends on lab values. So as a nurse, we have to monitor our lab values, our chemistry, especially for fluids, electrolytes, and things like that. And it also depends on the practitioner's choice. Would he or she order lactated ringer, normal saline? That depends. But as a nurse, we are supposed to monitor the fluid and electrolyte balance. So our goal, assuming we have this invasive measurement on the patient, is to maintain the pulmonary capillary wedge pressure between 10 to 15 millimeters of mercury. If the issue persists, so we replenish the fluid and we still have an issue with a low fluid, we will have to continue our assessment. Other causes that may cause low flow output is a cannula obstruction, and an assessment finding that will indicate that we have a cannula obstruction is an intermittent chattering sound on device auscultation. So what you do is you pick your stethoscope, you go to the pump, and you try to auscultate. So if you see this, if you hear or if you listen to this chattering sound, that is an indication that there is an obstruction in the cannula. It should be confirmed by the echocardiography. So our job as nurses is to make sure that there is no such sound. If there is such sound, we will communicate our finding to the physician, and he or she will order the test, and we'll take it from there to confirm. So the treatment goal is to maintain the pulmonary capillary wedge pressure between 10 to 15, as we said earlier, and to have a mean arterial pressure between 65 and 90 millimeters of mercury, and maintain the systolic blood pressure between 70 and 90. Remember, we are talking about a patient, with a device. So for these patients, even though it may be less for me and you, for these patients, systolic blood pressure between 70 and 90 is the goal. And then other things, as we said, we have to monitor our lab reports, the PTT, the goal is between 40 and 50 seconds, INR 1.5 to 2.5. Typically, in the post-operative days, these patients will be placed on warfarin on the second post-operative day if they are extubated. If not, it will depend on when they get extubated. And then they will be on prophylaxis, aspirin, starting on the first day post-surgery. All right, so the second complication we talked about is a right ventricular failure. And it's happening because we have fixed the left ventricle. Now we have too much volume coming to the right ventricle, but the right ventricle is not able to effectively pump that into the pulmonary circulation. So we're going to assess the patient, and when we assess this patient, we'll be looking at a JVD, jugular vein extension. If they are connected to an invasive procedure, we'll see an increase in the CVP. And if this happens with no fluid infusion, it tells us, the right ventricle is overloaded. We may see rhythm disturbances. We may see suction events with adequate pressure. So what's the treatment? The treatment for right ventricular failure is to reduce the afterload. We can use a vasodilator therapy for that. Or we may have to increase contraction. And to increase the contraction, we have to use inotropic infusion, inotropic drugs. Or we may have to use both, depending on the severity of the condition. But our job is to communicate our assessment finding to the physician. The other complication we have is hemorrhage. And hemorrhage is secondary to anticoagulant or antiplatelet medications. Cardiac surgery, these patients may have repeated history of cardiac surgery. Cardiopulmonary bypass, prolonged operative time, surgery took longer time than expected, and we may have device-induced coagulopathy. So how can we monitor or treat the cardiac dysrhythmias? All right. It may be caused due to electrolyte imbalance. So it's up to us to be on top of our labs and make sure that our fluid and electrolyte and everything else that was on the lab is within limits for that patient. Pre-existing conditions. These patients may have pre-existing condition because they have heart failure. So they may have a pre-existing condition such as atrial fibrillation that causes a dysrhythmia or disturbance in the cardiac rhythm. We may have VTAC, ventricular tachycardia, and it may be caused by partial or total decompensation. So what's our intervention? Our intervention is to monitor our labs as long as they are in our care. When that morning lab report comes, our first thing is to see the electrolytes, our magnesium, our potassium, our sodium, are they within the line? And they monitor their rhythms, every 4 hours, or depending on the protocol. We have to assess and make sure the lab values are within line and the rhythm is where it's supposed to be. The other problem we may have is secondary organ dysfunction. Okay, so we have to do an assessment to make sure that we have adequate perfusion to all of the organs. How do we do this? How do we ensure that we have adequate perfusion to all of our organs? One of the things is to do peripheral pulses. Now, it's difficult, if it's continuous flow, we may not have peripheral pulses, as was stated previously. So, pulses are not a good measure for us, but we have to assess for the color, worms, capillary refill of the peripheries. We also monitor our hourly urine outputs. Okay, 30 milliliter per hour is our goal, but we have to assess that continuously. We also have to evaluate level of consciousness. So that tells us, how the kidneys are working, how the brain is working, and how well they are perfusing. The other problem is infection. So we talked about previously about driveline care. That is in the hospital sterile procedure. When they go home, we educate our patients to adhere to aseptic technique. As nurses, we always have to make sure that we change the dressing every day. And as we change our dressing, we have to monitor for signs and symptoms of infection. The other thing we have to consider is we have implanted a foreign body in our patients, the device. And whenever we have a foreign body in the patient or in our system, that predisposes us to infection. So it is really, really important for us as nurses to make sure that the patients are free from infection and that we educate them to make sure that they know the signs and symptoms. So we can teach them to measure their temperature daily, assess the drive line, and see the temperature, the worms, and assess, educate educate them what the drainage is and things like that, so that they can effectively tell us what has happened. And as long as they are within our care, that we make sure our patients are free from infection. The other problem we have is device malfunction. We are dealing with a mechanical system, so anything can happen. We may have power failure. The cord may be disconnected from the controller. So these things will have drastic consequences. To avoid any adverse effect, it's therefore important for us to have secondary power sources, such as AC power adapters, batteries, and a second program device controller. When I say program device controller, a second controller that is programmed exactly the way the one that's on the patient is programmed, so that if we have a failure on the one the patient is on, we can automatically change it and plug it in, so we have continuous blood flow. We have to remember that the non-pulse-style devices, they don't contain valves. They have no valve. So what that means is, if the pump stops, that may lead into recurrent blood flow, which is also drastic. So we have to be aware of device malfunction, and then we have to be prepared to have our secondary sets of devices. And also to communicate that to the Lvad team on our floor or to the physician. All right, so this is another diagram. We looked at the video before, and then this outlines the various parts of the Lvad. This is a controller system. This is implanted. These are the batteries. But I think we have looked at a better video earlier, but this is another way of putting it. And then I'd like you to be familiar with the various types of Lvad systems. So we have the HeartMate, the Heartware, the Jarvik 2000, the HeartMate XVE, and the Thoracic. And knowing this is very important. If you are working on a cardiac floor and you have a patient who came from another place, and they tell you they have an Lvad, but they may not know what kind it is. So usually they have a color port. So the HeartMate 2 has a red, the Heartware has a blue, and it goes on like that. And then when you have this patient, when you do your initial assessment, it's very important to look at the controller and see the color port. They try to make this universal, so every patient with an Lvad unit will have this color port system. And then at the back of that paper, it may also tell you where the device was implanted, by what surgeon, and any other pertinent information. So I thought that's also important for the patient to know what kind of device they have. Here we just picked the HeartMate 2. That happens to be the widely used one. We have seen it in our Abington Hospital care for the patients. So this particular device has a drive line which connects the internal pump to the external controller and power source. It has batteries, for the controller. Okay, so we have to check the status. It has a system controller. The system controller is known as the brain of the device. It monitors the performance of our of our device, and it needs to be connected to the drive line all the time. All right. So I have this little video here that we can watch, and it illustrates.
Is located over on Flamingo Road. Tickets range between $5 and $18.
In our health news today, a high-tech device giving heart patients a second chance at life. Doctors at Memorial Hospital just recently performed their first heart transplant, but keeping patients alive and strong enough for surgery while they're on the transplant list is difficult. As our medical specialist Christy Kruger explains, that's where a device called the Lvad is proving to be invaluable.
It just got worse and worse because I couldn't move, I couldn't exercise.
Ken Iovino's heart was failing.
but overweight and bedridden, he was not a candidate for a heart transplant. Desperate for extra time with his family, Ken checked himself out of the hospital to walk his daughter down the aisle.
They just said you were too heavy. We can't do it with you.
But doctors did give Ken the Lvad, an implanted heart pump, hoping to give him a little more time with his family. The left ventricular assisted device, or Lvad, is inserted into the heart, helping pump blood throughout the body. It's connected to a battery pack that patients wear.
Oh, I can see it.
Yeah. If you can find one.
If I can find one. I'm sorry, I can't find one.
No, he doesn't have one.
In fact, Ken doesn't even have a real pulse. His blood flows continuously through his body thanks to that device. The Lvad is what kept Vice President Dick Cheney alive until he got his transplant.
In some patients, the device is used as what we call destination therapy, which means lifelong support. But for some other patients, this device is used as a bridge to transplantation.
The Lvad turned into an unexpected second chance for Ken. He began to lose weight and exercise under the watchful eye of medical support. So far, he's down 80 pounds, and now he is healthy enough for that transplant.
It really has given him an immunity on that. It saved my life, and it's given me more time to wait if a heart does come up. If not, I'll just live day by day.
Medicaid does cover the cost of the Lvad in most states. However, Florida is apparently one of 6 states where it is not covered, and doctors are right now working on trying to change that. The longest supported patient has been alive for 9 years with an Lvad. We certainly hope that Ken gets his new heart soon, and of course we'll let you know when he does.
If you take a lot of the event is located over on Flamingo Road. Tickets range.
All right. Very good. So we covered complications and some care associated with Lvads. So can you tell me a couple of complications?
Well, you can have a low pump flow,
Okay.
which is less than 2.2 liters per minute. You could have hemorrhage related to the cardiac surgery, related to anticoagulant or antiplatelet therapy. You could have right ventricular failure due to the left ventricular being supported and now the right ventricular is overloaded. You could have infection related to the surgical site, related to the driveline site.
Very good. That's very good. And the other thing we talked about is assessment. How would you do blood pressure on these patients?
You would want to use a manual cuff with a Doppler, and you would hear a whooshing sound. It would only be an assessment of the systolic
Excellent.
blood pressure.
Very good. Thank you.
All right. Okay, so now we're going to talk about patient and family teaching. You want to discuss the importance of follow-up visits so that the status of the patient's Lvad and status of the patient's health can be assessed at those visits. You want to have the patient know the signs and symptoms of complications. They should always know to carry an extra battery, an extra power source, an extra control device in case they need it while they're out. They should have a general overview of how the system works and a general overview of how the pump internally is physically working on their body. They should know their emergency contacts and understand emergency procedures. They should follow a cardiac low sodium diet. You should teach them their medications and the side effects of their medications and the purpose of their medications. They should know their physical activity precautions, such as don't submerge the device in water or don't participate in contact sports. They should understand how to care for their exit site, and they should also be doing daily self-monitoring of vitals and the system parameters. And that's the end of our presentation.
Thank you so much for listening. We hope that you have gained some knowledge and experience related to the care of the patient with Lvad.
And here are our references.